Uh, Microendoscopic discectomy (MED) for lumbar disc herniation was firstly reported by Foley and Smith in 1997. In 1998, Adamson and Broom applied this MED system for the treatment of cervical radiculopathy. After this report, endoscopic surgery for cervical radiculopathy has been reported from several institutes. We performed a cadaveric study for clinical application of the MED technique. We confirmed that the decompressed area was similar between the open method and the endoscopic method. The purpose of this presentation is to present our procedure of endoscopic surgery for the cervical myelopathy and to clarify the indication and limitation of this procedure based on the analysis of surgical results and complications. Our surgical procedure of endoscopic partial laminectomy is shown. The patient was secured in the Mayfield head holder and placed in the prone position. A 20 mm incision was made at 20 mm off the midline. Tubal retractor with 18 mm diameter was used. The best trajectory was slightly inclined from horizontal orientation. Endoscopic procedure is shown. This is interlaminar space. There is facet joint. The diameter of this bar is 3 mm. This is 2 mm caisson rondure. You can see yellow ligament. This patient has a calcification of the ligament flavum. And you can see the dural pulsation. The patient felt marked improvement of myelopathic symptoms. MRI showed complete decompression at C5-6 level. Analysis of surgical result and complications. Subjects were 41 patients with cervical myelopathy performed endoscopic partial laminectomy. Cervical spondylosis was 37 cases and calcification of the ligamentum flavum was 4 cases. Control was 29 patients with cervical myelopathy performed open partial laminectomy. There was no significant difference in age, gender, and disease between endoscopic and open partial laminectomy. We assessed JOA score, which was a scoring system for the treatment of cervical myelopathy by the Japanese Orthopedic Association. Frequency of analgesic use, neck symptoms, and changes of serum interleukin-6, which showing surgical stress. We also assessed complications of endoscopic partial laminectomy. Results. There was no significant differences in preoperative JOA score between the two groups. Both two groups showed significant improvement after operation. There was no significant difference in postoperative JOA score between the two groups. Frequency of analgesic use was significantly lower in the endoscopic group than in the control group within 1 day and within 3 days after operation. In the control group, 3 cases showed newly occurred axial symptoms after operation. On the other hand, there were no cases in the endoscopic group. Serum IL-6 increased 1 day after operation. The value in the endoscopic group was significantly lower compared to the control group. There was no severe intraoperative complications such as paralysis. However, 3 patients showed temporarily increased numbness of the hand. Recurrence of myelopathy symptoms within 6 months was seen in 3 cases. reoperation was performed in 2 cases. This slide shows 2 reoperation cases. Case 1 was a case of multiple level compression of spinal cord. Case 2 was a case of segmental OPLL. These cases showed improvement of myelopathy symptoms after endoscopic partial laminectomy. However, they had a recurrence of myelopathy symptoms within 6 months. Laminoplasty was performed in both cases. Discussion. Adamson described that myelopathy was a contraindication to the endoscopic procedure. However, we firstly reported that endoscopic surgery could be performed in patients with cervical myelopathy. From the current study, it was clarified that endoscopic partial laminectomy was superior regarding postoperative wound pain, axial symptoms, and surgical stress than the open method. Conclusion. Endoscopic partial laminectomy for the cervical spine diseases is a less invasive surgery, expected similar surgical result as open surgery. Thank you for your attention.
Thank you.